So welcome everybody. Thank you very much for staying with us on this very sunny day, but I think this session is going to be worth your time and attention. So I would like to first invite Professor Andrew Baker, BHF Chair of Translational Cardiovascular Science and Chair of Vascular Biology at the University of Edinburgh, a Fellow of Royal Society of Edinburgh and of the Academy of Medical Sciences. His research focuses on the mechanisms that control vascular damage and repair and how to influence them, and he's shortly going to tell us more about gene therapy.
Thank you very much for the very nice introduction. Pleasure to be here. I'm going to give you a talk about gene therapy and cardiovascular disease. So what I'm going to try and cover are a few things. I'm going to give you a little brief history of gene therapy to provide a bit of context of where the field's been over the last 30 years. Just to get everybody on the same page. I'm going to talk a little bit more detail about some pivotal cardiovascular studies that have shaped the field and where that field is at the moment. I'll give you a little contribution from our team and where that's going. And then some snippets for some improvements of how we can do gene therapy and how funders are also helping to change that environment a little bit as well. So gene therapy, and according to the EMA anyway, is these medicines contain genes that lead to a therapeutic, prophylactic or diagnostic effect. They work by inserting recombinant genes into the body, usually to treat a variety of diseases, including genetic disorders, cancer, and or long-term diseases. A recombinant gene is a structured DNA that's created in a lab, bringing together DNA from different sources. That gives you a flavor. It probably needs a little bit of updating, I would say. But it tells you a little bit about what gene therapy is about. Actually, the field goes back a long, long way. Really started to get some traction in the 90s, but even in 1966, we have text here. Finally, it can be anticipated that viruses will be effective use for man's benefit in theoretical studies, in theory for somatic cell genetics and possibly in genetic therapy. And then in 1970, this is completely visionary. The purpose of this paper is to consider three questions concerning DNA therapy of human disease. How great is the need? What models can we use? And also about health science community, political and lay community for the implications of gene therapy. And that's exactly how the field has been shaped. First gene therapy in human. This is from Rosenberg and French Anderson. This is about using retroviruses, which are very tropic for T cells. They proliferate and the DNA gets into the nucleus. This gives long-term stable gene delivery. This was proven to be very safe and effective in T cells from patients with cancer. And then a few years later, this is really proof of concept that you can take T cells, in this case, from patients with severe combined immunodeficiency disease, ADA-SCID, and get stable gene transfer. And that is both safe and effective over the long term. And that laid the basis for a lot of the studies that happened in Paris and Boston and Great Ormond Street around ADA and X-linked bubble boy syndrome. So this really ignited the field and a huge amount of input into in the early 90s. But then there were a lot of negatives in the late 90s and early 2000s, of course. Many people probably remember these, and if you Google gene therapy, these still come out. In 1999, Jesse Gelsinger died had ornithine transcarbamylase deficiency and died on a study that was injecting quite a high dose of adenoviruses directly towards the liver to do a gene replacement strategy. And although several patients got the same dose, Jesse Gelsinger died from multi-organ failure 3 days later. And direct response, cytokine storm to the adenovirus that was delivered. A couple of years later, of course, in these SCID trials then, because they were using retroviruses that go into the genome, they were a bit non-selective about how they insert their DNA into the genome. That can sometimes lead to insertion in the wrong places, activation of proto-oncogenes. That led to leukemia as side effects of these treatments. And this was also very prominent in the press. This is from Paris, but the same thing happened at Great Ormond Street. This hasn't been overcome, but it's been managed effectively. But this was very harmful to the field. A lot of companies left the field. Investment was very negative. Academics also left the field as well. This is early 2000s. Then there was quite a lot of a gap. If you went to the ASGCT or the European Society meetings, there was about as many people as in this room at the entire international meeting. It was really a bad time. But I think people who stayed in the field realized that we had to do a little bit of work together. So scientists, clinicians, bench to bedside, learning from what happens clinically, making things better, trying again, and that iteration was really important. And in the late 2000s, or the mid to late 2000s, there's a lot of sort of inching towards clinical progress in many of these areas. And then in 2012, there was a really important event. So the EMA approved Glybera, which is an adeno-associated virus 1 for familial lipoprotein lipase deficiency. So this is a very rare condition. There weren't many patients in the trials, but nevertheless, the EMA approved this, and this broke the back of the system and showed that gene therapies in the Western world could actually make it to EMA or FDA approval. The license wasn't kept in that, but it really was a pivotal moment in the field. And then, of course, we had lots of warmth and progress in a lot of gene therapies, particularly in genetic diseases, in hemophilia, in ocular diseases, bubble boy syndrome, and ornithine transcarbamylase deficiency. So this is the one that killed Jesse Gelsinger, has now been proven to be much more effective when you do it in a different way. And for genetic diseases, this has led to many approved medicines now, and the prediction is that this will keep growing and growing and growing. So this has really told us that the field that if you design and treat and have the right patient population, the right virus, the right delivery, and everything, then you can actually get this right and you can do something useful for the patient. The health economics, of course, around these treatments is also very difficult because they're very expensive and they're treating rare populations in general. So in cardiovascular, which is where I've been working for quite a few years, the first study in 1990, so 35 years ago from Betsy Nabel and Gary Nabel and team, showed that you can do, if you isolate a vessel in a pig using a double balloon catheter and you infuse some stuff between the balloons and let that virus dwell with the vessel, you can actually get quite good gene transfer. So this is using a retrovirus, as you can see here, or using just the basic DNA liposome complexes. And this showed that it was both efficient and also lasted for quite a long time. And this is quite important in vascular conditions because sometimes you might need long-term gene transfer, but sometimes you just want it in the short term. So you could then pick and choose which vector system you needed. So this was really the first study that showed it was possible to do this with the vectors that were available at the time. And then there were some clinical studies. So this is the first one. So this is from Jeffrey Isner, who took stock of the pioneering work of Judah Folkman in the VEGF field to say, can we take some of these vectors and overexpress things like VEGF, vascular endothelial growth factor, in patients with either critical limb ischemia, so peripheral vascular disease, or in the heart. This was the first study. This is an N of 1, basically, in this Lancet paper, before gene therapy, after gene therapy, where you can see some additional collaterals. And there were quite a few studies around this time of that. But never, to say, when these were moved into placebo-controlled trials, there was no real positivity. And this is quite a difficult field and remains so. Angiogenesis and neoangiogenesis and capillaries versus collaterals is a very, very difficult process to enact with single growth factors. So this was also quite disappointing in a way, as somebody who was fairly new to the field at the time, that these didn't translate in larger clinical studies into benefit. But that's still ongoing. So at the time, I think that there were some quite big hopes for gene therapy in cardiovascular. So heart failure was one of these, and so many studies looking at overexpressing genes that control calcium cycling in the heart to try and improve contractility, fractional shortening of individual myocytes, and then functioning of the heart in heart failure to try and improve that population. There's a study called CUPID that reported phase 2 about 10 years ago now that was negative. It was taking an AAV1 virus, putting it into the coronary via infusion, and trying to improve class 3 or class 4 heart failure. And that failed. And it failed probably because of delivery. Using AAV in that situation, when some of the patients went to transplant, the tissue didn't actually have any AAV in it. So it's probably a failure of delivery, not the theoretical process of overexpressing or manipulating some of these genes. And in vasculature at the time, very early on, there was a ton of different vascular conditions that were proposed to really benefit from gene therapy. Some of these are still real options, so therapeutic angiogenesis is still very much a target. Graft failure I'm going to talk to you about, as well as hyperlipidemia, but some of them have fallen away because they're better treated with small molecules, stents, and for example. So some of these early conditions are not translated now into active areas in gene therapy. So the area has definitely focused. So everyone who knows gene therapy knows that we work really on delivery. They're the three key things you need to get right. Delivery. And it's very difficult because almost none of these vector systems that we use are tropic for the vasculature of the heart. If you're in the liver, so modifying lipids through changing genes that are expressed in the liver, that's okay, or the hemophilia stuff, it's great if you're working in the liver, but the heart's much more difficult in the vasculature. So we really want intravenous delivery because that's minimally invasive. I'll come back to that in a moment. There are also catheter systems that you can use to either do retrograde perfusion, do perfusion into the coronary vasculature, or intramyocardial injection. So they're all possible, but they're all quite inefficient. There's also local delivery, so this is in graft failure, which I'll come back to in a moment, which gives you direct access to the tissue at the time of surgery. So I'll talk about two viral systems mainly. So adeno-associated viruses are very commonly used. So they've really taken over the world in terms of gene therapy for certain diseases. They're licensed for eye disease, also for hemophilia, etc. They're small parvoviruses that haven't been associated with any human disease. They do induce quite a lot of transaminitis in the liver a couple of months after gene delivery, which is problematic. But they do have long-term gene delivery, and this is very favorable for certain conditions. There are also a range of different serotypes. Jim Wilson and others have identified those over the years, and a few of them are tropic for muscle. So AAV1, AAV6, and AAV9, for example, are tropic for muscle. If you're into liver, you'll use AAV8. The genomes are relatively simple, and you can just replace these two genes by your therapeutic gene. One of the caveats is it's a very small bit of DNA, 4.7 kilobases is your limit. Manufacture is reasonable, of course, and one of the things that's really important, you get long-term gene delivery, but it doesn't integrate into the genome, so you have that safety feature as well. And there are many areas that have been developed for AAVs. I don't expect you to remember this, but this is a table from a review just out a couple of months ago that gives you all of the open trials in cardiovascular in the different diseases. And you just want you to notice that most of them use AAV. Most of them are in early phase trials, either in genetic cardiomyopathies or in Duchenne muscular dystrophy or hyperlipidemias. So this is a very active area. It's still quite young, and I think there'll be a lot of learning from these clinical studies over the next couple of years. As an example, this is from New England a couple of months ago. That's just reported the results of a phase 1. This is in Danon disease, which is a rare X-linked monogenic cardiomyopathy caused by mutations in LAMP2. So a gene replacement strategy. They're using AAV here, AAV9. They're not doing intracardiac, they're doing intravenous. So this is dose escalation per kilo into these patients. So when you do an intravenous injection of AAV9, it's muscle tropic, but it will go everywhere, and there's lots of studies to say that, but some of it will go to the heart. So you can put a cardiomyocyte-specific promoter on it. So while the virus might be everywhere else as well, you'll only get expression of your transgene in muscle. And they have shown in this study, because they took some biopsies from the heart, that you get nice levels of gene transfer in these patients. And you can quantify this looking here at baseline. There's no gene expression, of course. And over time, you do have quite robust looking gene expression from this delivery. As I said, this is using intravenous delivery. That's not without toxicity, but it is showing some signs that you can get some safe gene transfer into the heart that delivers some efficacy for these patients, but time will tell how effective that is in larger populations. Adeno-based vectors, of course, I think lost a bit of their traction from gene therapy all the way back in 1999, but are very useful. They've been used in oncolytics quite a lot in cancer because they're quite immunogenic and they can easily be made replicating. And of course, we all know and love them from the COVID viruses from the chimpanzee Chaddock's Oxford AstraZeneca virus, which was a chimpanzee adenovirus, and Janssen had an Ad26, which is a human adenovirus. Millions of patients, safe and effective. The genome of the virus is much more complicated and bigger than AAV. And in these first generation viruses, which are immunogenic, you only take a little bit out down here and replace it with your therapeutic gene. And this is why it's immunogenic, because all this stuff is here and still expressed when it goes into cells. But actually, in third generation vectors, you can take all of this out and it becomes much less immunogenic. And it's much more effective for vascular tissue. And so we're very interested in this vector system. I'll show you one example of this. So we're very interested in late vein graft failure because my work with cardiac surgeons over the years. We were very interested in this because of the clinical problem. 50% of grafts fail over the long term, and that is a big clinical issue. It's not for the immediate revascularization of the heart, but in the long term, the patency rates of coronary and peripheral grafts is really poor, and that hasn't changed in decades. And it's an opportunity to really do local gene delivery. So you have access in cardiac theatre to the vein. It sits there in a dish waiting for you to do something with it. You don't change clinical practice. And we know that if you can do local delivery, you have access to the very tissue you need, then you've got a better chance of doing something useful. And there are no small molecules or anything else that works to prevent bypass graft failure. So our mechanism here is to block vascular damage in a normal, well-functioning vein. Then smooth muscle cells are beautifully controlled by matrix. It holds them in a nice vascular tone, no proliferation. But as soon as you damage it by putting the vein into an arterial circulation, you get disruption here, and you get lots of pro-proliferative, pro-migratory signals driven by metalloproteinases. And these are nasty enzymes that we can block using inhibitors. So tissue inhibitor metalloproteinases are endogenous inhibitors of those MMPs. So our concept all those years ago was to say, well, we want to restore a low MMP environment rather than a high one because that's detrimental. We'll just take an adenovirus and we'll deliver one of the inhibitors, and that should be it. We've done this really well, I think. So we worked with some cardiac surgeons. We said, okay, what happens in theatre? Let's not change that. Let's just do the delivery in the right time. So this takes 30 minutes, takes a minute to cannulate. You can shove the virus into the lumen. That's just pushing the syringe, no excess pressure. And that's very effective. In 30 minutes, you get gene transfer that looks like this. So all these blue cells here have been infected by the virus. It works very well. It's very safe, and we can wash the graft out full of it. There's no virus left in the graft by the time it goes into the patient. So we developed the delivery strategy. If we overexpress TIMP3, so we just create a virus that gets into the cell, gets into the nucleus, doesn't integrate into the genome. Because this is an adenovirus, it chucks out loads of TIMP3 for a couple of weeks, and then because it's first generation, it sort of dies off, which is an advantage. TIMP3 is secreted, binds to the matrix, and from there it blocks the MMPs. So quite nice, so you don't have to transduce every cell also to get your effect because it's secreted. Here you'll see the efficacy and the mechanism. So this is a technique called in situ zymography. Wherever you see white, you see active MMPs. If you overexpress TIMP3, you block that beautifully. This is the pathological neointimer. This is in human ex vivo grafts here. TIMP3, we completely eliminate that. And we've done this also in pig. So again, if you look over here, this is an autologous vein from the pig. And 7 days later, this has been grafted. You can see very nice coloration. So this is very localized, high-level delivery. We've done studies at 28 days. We've done studies at 3 months. And you get very nice long-term improvement in neointimal hyperplasia. You can see this vessel with the TIMP3 in it is much better than control. This is all pathological neointima here. That is a surrogate for failure, and this is nicely affected by the TIMP3. And that tells you actually the virus is actually long gone from the graft, but we get a sustained effect. Okay, so that also is very good. So the adenovirus being transient in this circumstance is really beneficial. So what we have developed here is a within cardiac theatre gene therapy where we can take the graft, we can transduce it with the virus very simply, give it back to the surgeon, graft it, all in the cardiac theatre, and we hope this will maintain patency rates. So this trial is called PROTECT. It's funded by MRC, DPFS. We're doing this between the University of Glasgow and the Greater Glasgow and Clyde Health Authority. And we have MHRA approval and we should open in a couple of weeks. It's been a long task to do this academically, but we should be open to recruitment in a couple of weeks. So I think, last few slides, this is where we are. We have lots of modalities for gene therapy in cardiovascular disease. We have some pretty poor systems, but we have some nice opportunities for delivery. Okay, and we should get some approved therapies. We don't have any yet in cardiovascular space, really, but hopefully this will come. I'll show you 2 improvements that we need to make and why. So we need to take AAV. I've already told you it's not very tropic for cardiovascular tissue. We need to change that. Adenovirus is a bit the same. So we need to do 2, make better viruses for the cardiovascular system and provide transcriptional control. Okay. As an example of changing the tropism, this is some beautiful work from Patricia Muzzolino in Boston. So they've taken AAV9. We know the crystal structure of the AAV9 capsid, so it's, and you know exactly where you can put peptides in if you wanted to change the tropism. So they've put a vascular targeting peptide into the capsid, and you get hundreds of copies on the capsid when you form them. And this targets it to the vasculature, so now suddenly you can get very good gene transfer into small vessels, large vessels, pericytes, smooth muscle cells, endothelial cells. So it becomes a vascular targeting gene therapy vector. And that's very important because Patty is very interested in this very rare condition called multisystem smooth muscle cell dysfunction syndrome. There's a patient registry of about 60 patients worldwide. It's due to mutations in ACTA2. And this is very severe. Strokes occur in these children after they start walking, aortic dissections in the second decade of life. So now there's a possibility to deliver a systemic AAV. It targets the vasculature, and then you bring in the gene editing to correct the disease. And this works beautifully in a mouse. So they're moving forward now with this modified vector into a clinical study. The last thing is transcription. So we don't have to remember any of this, but in the very basic form, you have promoters that drive transcription. They can be viral promoters. They can be housekeepers that are active in any cell. You can make them specific to whatever cell you want. You can make synthetic promoters by chopping bits up, putting them together in a better formation. And they all work very well. Here's a classical example, shoving a mouse full of AAV9 with a CMV promoter, use a cardiac promoter. While the virus is all over the body, it's only expressing in the heart here. But there's all sorts of additional things we can do now, because what we ultimately want are small molecule controllable promoters. So in the presence of a small molecule that's completely safe, we would have active transcription. You take it away, it stops. So adding in that level of safety. And I just want to finish on what funders are doing now. So we're very grateful to the MRC and BHF who have funded us for one of these new MRC centres. This is called REACT. So this is a Research Excellence Centre in Advanced Cardiac Therapies. It's between King's College, Oxford, and the University of Edinburgh. And we're going at heart failure using these modalities. So helper-dependent adenoviruses, AAVs, nanoparticles, or RNA therapeutics, with the idea that we would derive curative, easy to manufacture, store and distribute, and cost-effective medicines for healthcare. We'll see how that goes, but we're going after cardiomyocyte proliferation activation of angiogenesis and modulation of fibrosis using those modalities. And the ability to use those funds gives the opportunity to put ecosystems together that are really important for development of these complex medicines. So where we have design, preclinical, together with manufacture, patients, trial design with clinicians, distribution, health economics, all of these in one place so we can help accelerate the pace of development. And hopefully after several years of this, we'll start to see the benefits of that investment from the MRC and the BHF. And I'll stop there. Thank you.
So thank you very much for that really clear talk, and you've also kept perfectly to time. So we have an opportunity for a question or two before we have our next speakers.
The mic is just coming.
So that was fascinating. What other changes are you making to the viral capsids beyond just the vascular targeting? Is there a duration of survival of the virus within the peripheral circulation that is optimal for therapeutic benefit, and can you adjust that as well?
Yeah, you can. So you can make things called escape mutants. So you can try and evolve capsids that are not neutralized by pre-existing antibodies that are prevalent. AAV8 is quite low, but some of them are very high, and for the adenoviruses, so they can evade that pre-existing immunity. Depending on what virus you use, adenovirus is hugely taken up quickly by macrophages in the liver. AAV is a little bit more longer lasting, but there are ways you can modify the capsid to both improve the kinetics of circulation as well as the sort of targets that they will ultimately find. And the final thing is you can make them improve the way they get internalized and traffic, because sometimes they don't get to the nucleus because they're degraded, and you can change the signaling mechanisms as well.
Maybe I can ask a question. You can't infer that infusing virus in different doses can induce side effects. So how do you decide how much virus to give to deliver significant gene expression in, say, in the heart, especially if you are not doing a graft and you're just infusing it or injecting it into the heart?
Yeah, I think for the cardiac gene delivery applications in that big table, there are two things cooking. One is the intracoronary delivery with the catheter, and that is easy for cardiologists to do, but the problem is that it gets flushed out really quickly. So the intravenous delivery is problematic because you're pushing the doses that are really going to become toxic for the patient to achieve the benefit that you need for some efficacy in the patient population. That's just where the field is.
Yeah.
There are companies that have developed and in clinical trials. So AskBio have a cardiotropic virus that they've generated that they're delivering into the coronary that shows much better uptake into the myocardium of patients with heart failure. So there are some improvements. It's not whether that's game-changing or not. I don't think we'll have to wait and see in these clinical studies. Yeah.
Great. Thank you very much. We look forward to seeing some of those results. Thank you, Andrew.